So I'd like to call on our last speaker, Dr. Jennifer Zhao. She's an infectious disease specialist and director of medicine global health residency track at Mount Sinai in New York, and she'll be presenting her late breaker abstract, which is entitled "In Utero Tenofovir Exposure is Not Associated with Fetal Long Bone Growth."
Okay, last talk. I'm going to try to be brief. Thank you all for hanging in with me, and thank you to the organizing committee for having us. Okay, as we all know, since 2010, tenofovir has been designated by the WHO as first-line ART in HIV-infected adults and pregnant women. However, there remain concerns on its effects on bone health, particularly evidenced in both primate and human studies. There are also concerns for decreased bone mineral content with in utero and postnatal tenofovir exposure. No studies to date have been published regarding fetal long bone growth. So we set out to test the hypothesis of whether increasing duration of in utero tenofovir exposure would be associated with decreased fetal long bone growth. Our study population consisted of HIV-infected pregnant woman fetus dyads who were enrolled in the MCH-ART study in South Africa between 2013 and 2015. Very briefly, the MCH-ART study was an implementation science study. It's ongoing and evaluating two different strategies on delivering healthcare to HIV-infected pregnant women and their children. So we included women with at least one fetal ultrasound, documented start-end dates of combination ART in pregnancy, and only women on a tenofovir-containing regimen. We excluded multiple gestation pregnancies and pregnancies which had resulted in a spontaneous abortion, termination, or intrauterine fetal demise. So our primary exposure of interest, again, is the duration of in utero tenofovir exposure, which we classified in these three following categories. The first one to the left there is tenofovir exposure since conception. The middle category you see is tenofovir exposure for at least 4 weeks and initiated after the first trimester of pregnancy. Then the final category is tenofovir exposure for less than 4 weeks or not exposed at all. Our primary outcome was fetal long bone growth measured by research ultrasonographers, which was assessed in the four following manners. First, we calculated femur length z-scores as well as humerus length z-scores, and then we calculated a change in femur length and a change in humerus length z-scores, basically taking the final femur length z-score and the first femur length z-score and subtracting those out, doing the same for humerus length. To evaluate the femur length and humerus length z-scores, we use linear mixed effects models where tenofovir exposure was considered a time-varying covariate. And then to evaluate the change in femur length and change in humerus length z-scores, we used linear regression models where tenofovir exposure was defined slightly differently, but as the number of continuous weeks on tenofovir prior to that final ultrasound. So in total, we had 1,030 HIV-infected pregnant women who had contributed 1,957 fetal ultrasound scans. You'll see there in the left column that 226 of these women at enrollment had been exposed to tenofovir since conception. The middle column shows that 232 women had been exposed to tenofovir for at least 4 weeks at enrollment. And then that final column to the right represents 572 women who at enrollment would have been exposed to tenofovir for less than 4 weeks or not exposed at all. And I just want to reiterate that the no exposure group is there because not all women, when they arrived at enrollment, were initiated on tenofovir immediately. And then just to highlight for you, the women who had been exposed to tenofovir since conception tended to be older and therefore tended to be higher gravidity. In addition, they tended to have higher CD4 counts and lower viral loads at enrollment, which is consistent with the fact that they were already on ART at enrollment. A quick note about the ART regimens that were used in this cohort. There was a universal backbone of tenofovir 3TC. In the group of 226 women exposed to tenofovir conception, 34 of those women were exposed to lopinavir-ritonavir-based regimens. An additional 104 were on nevirapine-based regimens, and then all the other women in the entire cohort were on efavirenz-based regimen. All right, this slide demonstrates the characteristics of each fetal ultrasound observation. And then you'll see in each column the number of fetal ultrasound scans that are belonging to each tenofovir exposure group. I just want to bring your attention to this column here on the far right, the 968 fetal ultrasound scans, which would have been done at a time when the fetus was exposed to either less than 4 weeks of tenofovir or not exposed at all. And in that 968 group, roughly a third of the scans would have been performed when the fetus was not exposed to tenofovir at all. And then bringing you down lower to the bottom two lines, we're showing you the z-scores for femur length and humerus length z-scores, and you'll see in unadjusted analyses that there were no differences between groups for both femur and humerus length z-scores. These are mean response profile plots showing the mean fetal femur and humerus lengths over time, femur on the left, humerus on the right. We see here that the lines are basically lying on top of each other, so this really demonstrates that there's no association, we think, with tenofovir exposure and fetal long bone growth. This is probably the most important slide of the presentation. So what we see here are the results for our mixed models showing the outcomes of femur length and humerus length z-score. We're showing here that even after adjusting for confounders, which we're listing below here at the bottom, we adjusted for gestational age, maternal age, gravidity, socioeconomic status, maternal CD4 and viral load, as well as maternal height. We still did not see an association between tenofovir exposure in utero and fetal long bone growth. Notice the non-significant p-values for both femur length and humerus length z-scores, as well as non-significant p-values for both levels of the tenofovir exposure. And I just want to point out the very small coefficients we see here, tightly centered around 0 with very narrow confidence intervals, which I think demonstrate again and re-emphasize our null findings. Last but not least, we did a subgroup analysis and took out the women who had to have had at least 2 ultrasound scans. This is roughly 2/3 of the entire cohort, or 660 women. And we also did multivariate analysis. Again, even after adjusting for the same confounders which we adjusted for in the mixed models, we still did not find an association between tenofovir exposure per 1-week increment and change in femur length or humerus length z-score. Again, non-significant p-values and very small coefficients. So briefly to summarize, I think we present novel data here on in utero tenofovir exposure and fetal long bone growth. Our cohort was comprised of HIV-infected women who were actually undergoing routine health care, which I think increases the generalizability of our findings. However, we're limited by a lack of HIV uninfected comparison groups. In addition, though our sample size was large, at least large enough to detect about a 1/10 of a score in difference in z-scores, any differences smaller than that we would not have been able to detect. In addition, any differences that were inherent between exposure groups in maternal immunosuppression may not have been fully accounted for in our modeling. And while we were able to assess bone growth, keep in mind that we were not able to assess sort of bone development at a cellular level, i.e. the bone condition or any pathophysiology in the bone. Lastly, I just want to acknowledge that our outcome was short-term. Therefore, I think long-term postnatal growth and long-term bone health are still in question. In conclusion, In utero tenofovir exposure does not appear to alter fetal long bone growth. I think these results are pretty reassuring and support the continued use of tenofovir in HIV-infected pregnant women. However, future research to assess bone health as well as long-term postnatal bone growth is still warranted in tenofovir-exposed infants. Lastly, I'd like to acknowledge first and foremost the MCH-ART staff and participants, as well as our two ultrasonographers, Pamela Niveling and Donnell Van Heerden, and of course our funders at NICHD for their support. Thank you.
Thank you very much, Dr. Zhao. This paper is open for discussion. I'll ask a question while people might be coming.
Group.
Given that all the women were eventually treated with tenofovir, do you, and hopefully that would happen earlier in pregnancy than later, do you think there was any discrepancy in the number of scans in the third trimester between the unexposed or short exposed versus the ones treated from conception or earlier? Because there's a greater proportion of bone growth in the third trimester.
Well, so yes, there would have been, because if you entered the study earlier, you're more likely, obviously, to have 2 or 3 scans as opposed to entering at 34 weeks and only having the 1 scan. But we think that having done that subgroup analysis where we took everyone out that only had the 1 scan and then looked at the change in Z-score, we still found the same sort of non-association. That sort of reemphasized and made us feel better about our mixed model. And then your second question was... was that your... Okay.
Thanks. Any other questions? In that case,
right.
Thank you
very
much.
much.
And I'd like to thank all of our speakers for an excellent session with great new data for pediatrics and adolescents, and the audience for coming and your interest. And if anyone has any questions for the speakers after the session, please come up to the front. Thank you very much.
Thank you.